Hello, hello. Good afternoon, everyone. I hope everyone's around. Why don't I see anyone? Oh, yeah, there you are. Now I can. So, today is an interesting day. We're going to have a very interesting conversation with a very interesting person as well. And we are going to focus today on artificial intelligence and its role on mental health. Today, there is no presentation. It's going to be a conversation, and we'll take a lot of questions. But till we have Saurav who's going to join in a short time, I am going to take any questions that you have from the past couple of days. If you have any questions, let's do that before we have Saurav joining in, and then I'll talk about today's topic a lot more. So, yeah, if you have questions from yesterday, day before, any thoughts, any comments, anything, feel free. And since today I'm taking the session, we'll get a lot of breaks because we need breaks because we need to have chai and nibu pani regularly, right? Okay. If there are questions, good afternoon, everyone. So nice to have you all here on this conversation. I hope it's been a learning experience for all of you and you've enjoyed it. Learning happens maximum when you enjoy it. How do I get relevant experience in case history and MSc? See, the honest answer is that how most people would have studied, or let's say what I have also done. So you first learn academics, you books and reference books and lectures. Once you gather that knowledge, then you go next step. You start engaging with people under supervision, and then you learn that. Then when you miss out on something, go back to the books, learn more, and the cycle of learning continues. Now the issue is that um, it's not very easy in a branch like ours with the confidentiality and the ethics of it. Then one can merely have observers, and especially in institute like ours which are not academic oriented institute, or let's say where people are coming. These are general hospitals. So what happens is that most people are very uncomfortable, which you and I would understand why, right? To have an observer. And when it comes to telemental health, so if I am, let's say, if this was a teleconsult, I can't have somebody sitting here and learning or observing notes. Ethics is a bit of an issue. We don't do observerships but primarily because of the reason that I shared with you. But yes, I do feel in a lot of very, very good colleges, especially government colleges and hospitals like from where we studied. I think that's a place to go to. Um, I'm not the expert in these answers on licensing, but yes, if you've done your masters in any form of psychology, we would that's uh, when we take people on board as counseling psychologists. My initial thoughts on AI I'll give when Saurav joins in because it'll be interesting for you as well because I'll come from a pure clinical background and he'll come from a solid data um, technical background, and it's going to be, if it's okay, the therapist doesn't charge for the therapy. Yes, it's our decision. We can decide how much to charge. We can decide if not to charge. But whatever we do should be before starting these sessions. That is ethical, which means in transparency, I have told you what I charge, what I do, and that's how it should be. One second, I just missed a question. Is this I could So, irrespective of the school of thought, whether it is a psychodynamic approach or a cognitive or a dialectical support, I mean, lots of approaches are there, right? Diagnosis is in any case evolving. What I may feel on day one may not necessarily feel on day 30 because you start knowing a lot more. When I look at diagnosis, I'm not just merely looking at a DSM or an ICD-10. I'm also looking at the dimensional component of understanding diagnostically what an individual would be having. Now, that will start from your first introduction, and as you have more sessions, you start understanding a lot more, and your First session is also treatment in a way. Every interaction you have is therapeutic. Certificate, if you're asking for the previous one that I took, that will be probably be there in your mailbox by Monday or Tuesday. I just had some minor issues. I closed them in the morning. I have in my own approach, I have not differentiated between which college you studied from, whether it's distant or otherwise. I look at the approach that individuals have, and that's how I work with people. You work with people. Education is just one layer, which is like a line to cross, and then you have to still do what you have to do. Mere qualification doesn't do much, but having it is a mandatory, right? If a therapist is recording a conversation, ethically you should first tell that to the patient or your client. You can't record without information. No, we don't have offline internship. No, masters, so you will have to do. Popular reads. Academic, you have your own list. I do feel non-academic reading also has its role. I'd like to read a lot of biographies. I like to read stories, including fiction and historical fiction and contemporary fiction from various cultures and countries. I like to do that. Um, and I read a lot of nonfiction. It just helps you know so much more about other people's vantage. More often than not, we live a life almost in an echo chamber. We have one interpretation, one view, it never changes, and then we keep feeding onto it and onto it. That's not how it should be. We need to be a lot more lateral in our life. Mistakes we'll make, we'll all make some mistakes here and there, which is fine. You learn from them. But the mere fact that we believe that I am only right and I can't be wrong, and my view is the only view, that is not that doesn't work in life. So when you are talking about how to start your own organization or your own private practice, go ahead and start. Start whatever you want to do. To go ahead and move forward, and gradually you will also learn in the process. Make sure that the key aspect, maintain your ethics and values. If you're working with people, make sure you build teams. You have to put a lot of effort. If you have to build teams, it's not something which is going to happen without putting an effort. And just because you lead an organization, that doesn't mean you stop putting an effort into people. You will have to do that. Will you get to see the correct answers to the assignments? I have no idea. I think you can ask that when Anuna ma'am or Roshi ma'am come. They'll probably be in a position to tell you. Yes, I mentioned it's quite okay if you decide not to charge. No, a master is a master. If you have a degree which is recognized by the law of the land and in whichever country you are, it's as good as any other degree. Side E questions I'll let Roshni answer. My opinion on self-help books, it'll help some people, yes. Some people are helped by self-help books. A lot of people may not be helped by self-help books because one size doesn't fit all. Different people have different approaches. Let's say I listen to Hindustani classical music. I may not listen to some other form of music. You may like that music. That doesn't mean that that music is good or bad or you are right or wrong. We all have different choices, different personalities. And based on that, we choose what we choose. So you can, without hesitation, if it works for you, you should read them. Does language become a barrier in a therapeutic alliance? It could actually. Sometimes it does. Sometimes, let's say the patient's comfortable in a particular language and the therapist may not be comfortable in that language. Sometimes it may be a hindrance. I can't say that it will always be the case, but sometimes it may well be. If you are telling a patient that your session is being recorded and they are guarded, so first of all, you can't tell a patient, you will ask a patient, which means you can ask that I want to record. You will tell why I want to record for A, B, or C reason. Then you ask, are you comfortable? You'll also have to tell what you're going to do with that recording. You'll have to address the confidentiality privacy factor. And then if the person says yes, ideally this is a consent which should be taken in writing. But my opinion is trying to record or trying to record at the cost of the rapport or cost of the comfort of the patient. This is not, it's just very avoidable, to be honest. I would not record sessions. I'm not very comfortable with the idea. And sometimes I feel that because someone's come to us for help and I'm asking them something, they might just feel forced to say yes. So that's why I think just staying within those boundaries is something which we should do. I am not fully aware of the RCI guidelines, to be honest. I am aware a little bit, but the RCI guideline related questions, if today or maybe one of these days you can just take them up with Roshni, she'll be in a better position to answer that. Non-academic book, just pick up any non-academic book and it'll help you in psychology because it talks about humans, right? It may be views, thoughts, behavior, actions. Feel free and do that. Can you be a therapist for your family? No, you can't. I don't think it works. We talk about non-judgmental, not having a vested interest, bias, vantage point, emotions, being open. That's not possible. Right now, to be a clinical psychologist, you, I think, need an MPhil or a PsyD, and then I think there is also one of that courses that Roshni had talked to you about. But basically, you need a license to be able to say that you're a clinical psych. My thought around paid internships, I'm not very comfortable with the idea of charging for internships. Everybody has a right to do what they do, entirely up to them. We don't, I don't. Is it worth it? Which means if you would have paid for this internship, would have been worth it? I don't think so. Even if I would have charged you rupee a session, am I worth it? I don't think so. But out of your own knowledge, a need, and out of your own interest, you're being a part of a conversation. You may come and go, you may stay for a while. You choose upon that, right? That's absolutely fine. But I am not comfortable with the charge aspect. I'm not sure it really matters. You like the plants? Thank you. I appreciate. I like the plants as well. Attendance link has been shared. They'll share it once more. I'll come to AI very soon. Substance abuse is a form of an illness. Psychopathology, which is the pathology of my psychology. So that will be happening anytime I have, let's say, any illness. My psychopathology of depression, psychopathology of schizophrenia, psychopathology of substance use. That's how you see it. You can practice counseling after completing your master's, yes, without a doubt. You can you can work with a hospital, for example, ours. You can start your own practice. You can work with a school. You can work with a college. You can work with an NGO. There are various aspects you can do. There is no fixed number as to how many consults the patient would be comfortable in. I mean, the number may be even zero at times. A person may have a pre-rapport before even coming to you in a way, or it may sometimes take several sessions for the rapport to happen. There are various aspects of resistance and understanding and insight which are also at play here. No, I don't think getting therapy is a luxury of people. If I have an illness, and if in my illness I require, let's say, therapy to get me out of that illness, how is that a luxury? It's my basic need. It's my human right, on the contrary, right? Mental health is a universal human right. Yes, for us it is. If I, as a medical doctor, will need to have different licenses, yes. Financial scope of psychology, you'll lead a good life. Yes, you can do counseling after your master's in organizational psychology at your workplace also. How does a psychologist manage their own mental health? There is no one rule for all. We all try to manage in our own way. I'm sure you do, and so do we. So sometimes it's a didactic form, sometimes it is an individual form, sometimes it's a social form, sometimes it's a more mindful form. There are various aspects to our life. Art therapy, I think, is effective. We have an art therapy based program in various clinical conditions, from depression to the rehab aspect of psychosis to a role in substance abuse, a lot of role in children, in geriatry. There are lots of aspects where art therapy as evidence that it will work. No, not my journey. I'm not sharing my journey today. It's such a but what I joined my college way back in 96, 97 in psychiatry. That's almost like 30 years back. Today we do artificial intelligence. I struggle with both artificial aspects and intelligence. So that's why today we'll have the more intelligent person who's not artificial to talk us about intelligence, so that my lack of intelligence can be substituted by the wow intelligence of our guest today. Um, yes, after masters you can work with photos, of course. Why not? If you're conducting a mental health workshop, will your relation and boundaries with the client be different from normal therapy? I think two different things. When I have a workshop, I'm doing a group interaction, which is not a one-on-one interaction. It's the nature of the workshop is very different, and the therapy is very different. I don't think one affects the other. We do not have offline internships at Fortis, to be honest. Um, you may have liked certain things I've done recently on social. Some of you may not have. You're both welcome, and people will have their own views. Most people don't have 100 on hundreds score. Some will appreciate what you do, some won't. You take both in the spirit of what it is. Let's do one thing. I think I can see the absolutely brilliant sort of Banerjee here already, and I'm going to try and log him in so that we can talk about what our topic is, and then we can come back to some of these questions. But I'll just take this question: is it ethical if somebody does pro bono immediately starting in your career? If you are transparent about your pricing structure before the person comes to you, then it's fine. Saurabh, are you here? Are you going to join us in some time?
Yeah, doctor, I'm there. I'll be able to come on camera in exactly 5 minutes from now, if that's okay.
Okay, absolutely fine. We'll wait for you and I'll continue taking some more questions. People, I have 5 more minutes by myself before the genius of Saurabh comes. Uh, Scope of research in India is good. I do feel that we need to have our own research and we need to have a solid research. Yes, recording this will be available for I think a couple of days. I don't know how many days to be honest. So I'm not going to overcommit. I overcommit, then these people come and scold me. You may think I'm the senior most person in this program, which age-wise I may be now, but I had a scolding from everyone. It's probably fashionable in any case for 20-year-olds to scold 50-year-olds nowadays, right? Especially when it comes in the public domain of social media. Yesterday's teacher is my favorite also. You're talking about Mantosh, right? Mantosh right now has gone trekking. He took your class and now he's gone trekking. So he's left it all to me. But it also depends, to be honest, a lot on the topics also. I think mental status examination is a very interesting, intriguing topic. There is always so much more to learn every time we talk about it. Different topics will have their own, and yes, Mantosh is a brilliant speaker as well. Paid internship for psychology, I'm not a very firm believer in it. Wordplay, say it as it is. The play will be done after you've said what you say, you say. Yes, we'll continue to have online sessions. In fact, towards the end of the year, we'll have what we call as the Bharat Panchal dialogues. Bharat Panchal sir is my teacher, and now we've been having Bharat Panchal dialogues every year for the past, I think, 4 years, where we invite speakers from across the globe to have a short interaction session with all of us, and we learn from other people's experiences. And we will be doing that sometime later. Yeah, neuropsychology is a good branch. Um, See, salary is you need to understand that it's not merely the branch and the salary. It's also um, years of experience, nature of work, how well you've done. So a lot of things change accordingly. It's not like one line. Do clinical psychologists get their white coat? I don't wear a white coat. I've never worn a white coat. At my work, I don't wear a white coat. I'm a mental health professional. I do counseling. I'm not doing any of those medically things. So most people in our program, psychiatry, all psychologists, clinical counseling, art, sport, psycho-onco, most of us actually don't wear a white coat. How to make parents understand about this career in psychology? I empathize and identify. I'll tell you a story. Right, way back, this is like I said, 96, 97, when I was supposed to start my post graduation. I went for the discussion with the exam, the academic guides. So in our field at that time, you would go and say, okay, this is what I want, and they'll say based on your um, the scores and your list, what you can get, what you can't. And I said psychiatry, and everybody in my family also was saying, why psychiatry? Why psychiatry? Do this, do that. People will have views about the branch. We can't do much about it. You like it, you believe in it, you do it. A best decision of my life any day. Um, and no regrets. In fact, I don't think I could have done anything um, else. But we also need to remember we are all students. Just because you have been there more than if most people have been, that doesn't make you better than anybody else. In fact, like I told you on day one, younger people know a lot better than us. Um, that's how I see it. Yes, trans movement therapy has its own roles, to be honest. Yes, it does. Yes, counseling psychologists work in a hospital. In fact, our hospital, for example, our network, we have so psychologists outnumber psychiatrists in our program. I mean, almost 1:4 kind of a ratio. We have counseling psychologists who are all masters. We have clinical psychologists who are MPhils. We have art-based therapists who've done masters and an art-based work. We have psycho-oncologists um, who've done masters in psycho-oncology or in MPhil. We have psychiatrists. We have de-addiction psychiatrists. We have a psychiatrist who's also an expertise and has done some course in eating disorders. We have, what else do we have? Psychodynamic, psychoanalytical therapists. I hope I'm not missing anyone. Otherwise, in this world, what will happen if I miss something? One word you miss here, one word you miss there, and by the evening, it might well be viral. I can't name one book to be honest. I've just every time I read something, it makes an impact because you learn so much. But yes, way back, and I don't know whether you've seen this show or not, but way back again when I was doing completing my MBBS mid 90s, I'd seen this show called MASH. I think it's Mobile Ambulatory Surgery Hospital M.A.S.H. I think that did make a bit of an impact to a much younger version of me. So yeah. Uh, Jobs open in Fortis after masters. Yes, we do take psychologists with masters. Yes, you don't push someone towards therapy. You share information about therapy. You share information about how it can help them and how it can help them. That's what you do. Pushing doesn't work, but sharing information, giving them time, that's how it'll work. I think online or offline both have their own meaning. Whenever you get an opportunity to learn, and if you feel you are getting something and you are learning something, you should do it without a doubt. If a patient is getting irritable because of boundaries, you will need to gradually work towards the patient's understanding of boundaries. But you can't let the boundaries being crossed because it will compromise the efficiency of your work. So, boundary is not merely about safety, boundary is also about creating a scientific structure which can ensure that the clinical delivery has its own efficacy. Real life practical answers to financial conditions of psychologists. I would not club any industry or any branch or any field in one group. I would also simultaneously say that one needs to appreciate and understand that in each field you will have people at different stages and phases of their career, and based on what they've done and how they are doing and effectiveness, luck also, to be honest. I mean, I'm not going to take that away. Being at the right time in the right place, I don't know how else to call except luck. But there are so many factors, to be honest. Some of them are internal, but a lot of them are external also. So I don't think remuneration can be seen only in terms of a branch. We don't conduct offline internships only because we've realized if you were here, you would not get enough exposure because more often than not, people will not want an observer. So we realize it becomes a bit of a waste of a time. So for you all, and it's not fair, which is why we don't do it. Okay, you want it in Microsoft Teams? I think we can do that. Not a problem. Next time, but next year, not this year. Which questions? You said you've answered some questions. You want to join Fortis after Masters? Send a mail to mentalhealth at fortishealthcare.com. If we'll have a position, you'll get a call. If you liked what I said on a social media platform, then you are amongst some people who do. And I appreciate like those who don't. And there will always be two sides to a way to look at things, right? So best options other than clinical psychology, counseling psychology, psycho-oncology, art-based therapy, sports psychology. All of these are fields where you can have varied level of success as well. Merely one kind of a subset of a branch has more or less success is uh, not the best way to look at it. We have to work with across the board, whether you are working with elderly or whether you are working with young people, whether you are working with any subset or a group, you still go with empathy, you still go without judgment, you still go with your knowledge, you still bring clinical efficiency. आज की attendance sheet shall be added again and again, so don't worry about the attendance. I hope so. I hope there will be more institutions where there can be more mental health professionals come. I mean, right from psychiatry, clinical psychology, counseling psychology, psycho. I mean, every field. I just feel we need more experts, and I hope there will be more. I completely understand your question and endorse it. The process of becoming a counseling psychologist is doing masters in psychology and starting work. Training programs we don't have for psycho-oncology. We have a program of psycho-oncology. There are very good colleges providing for the qualification. No, it is not possible that any of your friend is in any of the Fortis hospitals in Delhi and paying and getting amount. I don't think that's possible. So there is some confusion. We don't charge for internship. We don't charge for education. That is something we are very, very clear about. And can't be at Fortis, I would have known. Okay, young people, your and my conversation can go on and on and on and on and on. So what we'll do now is we're going to take a pause and we are going to have the absolutely bright, brilliant mind of Saurabh Energy. Every time I talk to Saurabh young people, I learn. One, because the mind is way too brilliant and bright. And probably the reason why he talks about artificial intelligence is because his intelligence is like, wow. So my intelligence, Saurav's intelligence, right? So we will today learn about artificial intelligence. So I am going to make it very simple. I am going to ask a few questions to Saurabh first. Okay? Once I ask those questions to Saurabh, and then you and I will also ask him questions. For your understanding, he is the brain behind Stella. I've started calling Stella Stella Parekh. Saurabh prefers Stella Banerjee. Anuna prefers Stella Bordoloi. And Roshni prefers Stella Abbey. So any version of it. But Stella is the AI, psychological first aid, one of the world's most sophisticated psychological first aid that is made by the one and only Saurabh. So we are going to start asking Saurabh questions, and for some reason I can't see him again, but now I can see him. So we are going to ask Saurabh about artificial intelligence, and I'll share with you my views also, young people, and I'll take all your questions to him. So let's start with this. Saurabh, I know every time I have asked you a question, what is artificial intelligence, you say the word only is wrong. So at the cost of being corrected again, can you please tell us what is artificial intelligence?
Artificial and not so intelligent. So I am sure about one thing, which is it is artificial.
in terms of intelligence, we can discuss a lot. It is not the traditional way of us understanding intelligence. You will be able to tell that better what is intelligence, but in terms of how we understand intelligence is slightly different, and I can discuss about that in the course of this particular discussion. But one thing I can say, in artificial intelligence we get a lot of data. I'm just giving an example, like if I ask a question like what is the color, most of them people will say it's gray. Question is, why will people say it's gray? Because we were trained in our childhood to say similar colors as gray, right? So as human beings, the same way, if we train a system similar things over and again, that this is gray, this is gray, this is gray, now I see something similar to gray, I will be able to say, okay, this is also gray. And this is how the human training happens, and with that we have some intuition about something, inferential learning. We infer, okay, fine, this can be this is what we already know. The same way machine can also do certain things similar way. That is, if I am being trained to say something as gray, I can detect, okay, something similar to gray will also be told as gray. Now, I do not know if that should be called as intelligence, but yeah, this is what is. And if we recreate that artificially, we call it artificial intelligence now.
So tell me, I mean, I was talking about Stella. So young people, United We Care is where Saurabh is the founder of this platform, and Stella is the artificial intelligence psychological first aid, first responder of sorts, right? And like what Saurabh was saying, so the AI is trained into psychological first aid, so acts as a screening, not diagnostic, but as a screening, a pathway, a reminder, an initial intervention, like how a well-wisher could give, who may not be a qualified expert, but would still be able to give the right kind of response. So that's what Saurav's been able to create. And what that does is it allows a whole new layer. So when you were asking me about artificial intelligence, that what is my take on it in mental health, my take is very simple. The percentage of people who are having mental health illnesses is huge. The percentage of people who are having mental health concerns, which may not be illnesses, is bigger. Now, the experts is very less. These experts are also disproportionately divided. So now, those people who need some help, not necessarily needing to go through sessions or meds, what do they do? If all of them come to experts, then those who really need us will not get this time because there are less experts. So, what is the solution? How about having a layer? In fact, if you ask me, I'd love to have a layer of family physicians also. I think over the years as a society, we've kind of done over expertization of medical field, that you have a stomach thing, go to a gastro specialist, you have a headache, go to a neuro specialist. How about also looking at the family physician route, trust, rapport, understanding, knowing you, knowing things well enough that would be able to then guide, hey, you may take this help, do this lifestyle correction, it's fine. Or, no, you know what, go to this family gastro, start treatment, I'll talk to them and I'll try and maintain that for you. So it reduces cost of treatment, it increases access of treatment, and it brings a personal positivity that the human care. Now, the same, if you look at layers, so if there was a layer of AI, a layer of family physicians, you add psychological first aid at a societal level, and now you add the experts, you have a pyramid that can take care of mental health concerns. But if you remove the bottom of the pyramid and just have that small little triangle of clinical psychologists, counselors, therapists, psychiatrists, and that's about it, you will not be able to take care, which is where AI comes into the picture. Are we where we would have wanted to be in AI? Of course not. How can we be? I mean, will AI be different 50 years down the line? Of course it will be. Hasn't psychiatry changed? I mean, DSM changed so many times. Why? Because clearly, when they gave the first list of disorders, they realized with experience something needs to change, and it became different and different. Then, even in 5TR, you had newer illnesses coming in, some illnesses, diagnostic criteria changing, some illnesses, categorization changing between, let's say, 4 and 5TR, that OCD, which was anxiety, picked up and made into a separate, PTSD, which was anxiety, picked up and made into trauma related disorders. That happens. Why? Because science evolves and learns. Do we have the perfect science right now? We don't. But should we shut our eyes and say until it is perfect, we won't experiment with it? That is stupid. Because the first car when would have come was certainly not the cars we have now, and it's certainly not going to be the cars of the future, right? So that understanding you have. For me, young people need to have openness. Don't be rigid. Don't be overcritical. Be willing to explore within the domain of what you understand and what is best in the given moment for your patient or client. And I think that's where AI comes into the picture. And this is where, after giving you my opinion on AI, I'm going to go to Saurabh and ask him, Saurabh, in mental health now, let's see, right? We've heard about AI working in other aspects, but in mental health, where do you see, not just now, but in the future, where do you see AI's role? And more importantly, once you tell us about the role, also tell us how exactly does AI work? I mean, in the context of mental health. And take your time. We have several hours with you. Although we all like a tea break, and we'll be having one soon. Every 45, 50 minutes, young people take 2 to 5 minutes of break. So now all yours for a long time till the first tea break.
Sure. Thanks, Doctor. Okay. Uh, this is a pretty long question, so it will take a lot of time to kind of answer. So I'm dividing it two ways. Uh, First is why. Why do we need AI? And second would be how. How, or what is AI was a very basic answer, but now we will go deep into how AI works, and how AI works for mental health domain. So the first part is why do we need, or where in mental health do we need AI? See, uh, let's understand two data points. First is, at any given point of time, 85% of the population, they are in the subclinical preclinical state, and then there are 15% who are in 10 to 15, we define it whichever way we want, they fall under the clinical state. Now let's do the basic maths. What is the population of India? It's about 1.4, 1.5 billion. 15% of that is a humongous number who need clinical support, and yet we will have few thousands of clinicians. I mean, the requirement in the market, the demand that we have as a mental health services, do we have enough clinicians for that? It's the first question. Second question is, out of this 85% who are in the subclinical state, the data shows 1 in 2 in our lifetime will require mental health support, right? So which is like 50% of the overall population will some point of the time or the other in their lifetime will require professional mental health support. Now, if we do not handle this subclinical preclinical state thoroughly, we are also exposing those subclinical preclinical population to fall under the clinical population sooner than later. And with the change of our lifestyle, over the lens of lot of technologies, I'm being very cautious because I come from technology domain. Not all technologies are bad. It's like everything. I mean, this is water. I take water way too much, it's harmful for me. So anything beyond proportion is not so good. But so there are good side of technology, there's bad side of technology. But AI specifically would be extremely important in, as doctor was talking about, in screening part, screening at scale. So when we say every place from now on, we will be talking about scale, because as human being, we have a limitation on the scale, because I mean, let's just take the example of a typical day of a psychologist. You'll have a session, mm, that will have a duration of somewhere between 45 minutes to 1.5 hours. It depends on, like, how the sessions are structured. So if we on an average take one session 1 hour a day, practically we cannot take more than 8 to 10 sessions a day. I mean, that's a human limitation, right? So we are talking about, practically we cannot reach more than 10 human beings a day. But AI does not have that limitation, right? So it can reach n numbers of human beings at the same time. So, for the basic screening purposes, generic population, they have a lot of questions. Do I have anxiety? Do I have depression? Now, do I have anxiety or depression is for clinicians to say. But are you at the risk of having anxiety or depression, that you should be talking to the clinician? Can we have technology to say that bit, that, hey, you might have a very high risk of anxiety, so please go and talk to a clinician? At least that bit can be done by technology. Now, this first can reach to the population to start with AI. That's the first part. Second part, let's now go into the assessment part. We all do the assessments, right? Now let's go back a step into the past. How did we create these assessments? Were they created for Indian population? Are they created in English, or say in Tamil, say in Bangla? So suppose there is an assessment that was created in English. Now there is this Bengali woman. She does not understand. I mean, she understands English, but is not a native speaker of English. Now, if you just open a common psychometric assessment, the first question of it, G87, I keep showing that, and you can just help me translate that into the language of your choice. GAD7 first question is, do you feel anxious, nervous, or on the edge? How do you even translate it in Hindi or Bangla or whatever languages that you speak? Because we may not have the cultural nuances of those set of words in our language. But what happens is, then we are dependent on the clinician to give the translation. Now, if we have clinician to provide the translation on the go, there are two risks that we run right now, right then and there. One is, it's a sheer waste of time. Like, I mean, I'm not expecting the clinician to be a translator of a language, right? No, that's not the job of the person. So the clinician should perform at the top of their license, not at the bottom of the license. Second thing, a bigger danger is, every clinician will have their own way of translating that. Now we are talking about inducing a human bias to the whole system. Now, me, Dr. Parikh, we discuss a lot. Mental health does not have any objective assessment. You take a blood sample and you test for something, which is say blood sugar, and you tell, okay, this person is diabetic or this person is not diabetic, given the results that we get. In mental health, we don't have that. It's always subjective. I mean, we are close to getting few things on that domain, but they are very early stage in terms of their go to market. Like, there no way they can be called as viable in the market right now. So in that scenario, we are and even we talk about DSM. Have you even thought, why do we call it DSM? ICD is International Classification of Diseases. It's disease. In DSM is Diagnostic and Statistical Manual. It's a statistical manual. So we have to always remember that it is statistical at the end of the day. So when it is statistical, it is sensible to do the statistics for as wide a demography as possible, as wide a cultural nuances as possible, and as wide a geography as possible. I mean, me and Ritu, we used to have conversations. So Ritu is my co-founder, and I'm not naming the relationship, but she knew a person who was having major issues with her mental health. She was taken to USA, and after attending couple of therapy sessions, her mental health went terribly worse, just because the therapists in USA did not understand the cultural nuances or the cultural realities of India. What is 100% acceptable or can be a root cause for a major mental health concern in India might be a complete, I mean, there are cultures wherein we don't even understand that. So in essence, we are talking about huge amount of these similar assessments to be converted in the local languages. And it's not only about translation. We also have to readjust the statistical parameters of those batteries that we are talking about, because something which is a mean for a North American white or black woman, that may not be the average for an Indian woman or an Indian man or an Indian mid-age person. It will differ, and we do not have enough manpower to convert it. We must use artificial intelligence into that bit. So the first one, screening. Second bit, conversion of the screenings to the languages of the masses. Conversion of those same screening to adjust the mean. We look for a number. GAD7, your score is say 16 out of 21. A very high anxiety, possibility of very high anxiety. But is it possible that for a different population that number is different? Very possible. So we need AI there. The third bit, it takes humongous amount of time to create the case histories, intake forms, and in mental health, because it's so complicated. By the way, I'm a mental health patient myself. So, I mean, the kind of files that I have, it's about 40, 50 pages long. So every time I go and consult a clinician, somewhere I have to communicate that these things had happened, and and that is time consuming. Again, the point is to allow clinicians to function on the top of their license. Like, can we have AI to do the note taking and the case history of that? Next bit is, see, most of the times we talk about therapy, medicine, lifestyle, whatever we talk about, they are repetitive. I mean, we have to repeat it every day. We cannot do it like once and expect the whole problem to be solved. We have to go for the repetition. So the reminders, every day to be reminded of, okay, fine, I decide tomorrow onwards I will do yoga and meditation. Can I do it tomorrow and expect everything to change? No, I have to do it every day. Every day. So, it's about habit, right? So AI can work as a part of the habit formation. The next one is relapse. So I was talking about 5 major places wherein we see right now we need to have data science, statistics, and other technologies to be used. The fifth one is the follow-up and relapse management. When you consult, the person goes to their home, and then there is a possibility that the condition might elevate, or there can be comorbidities that might be detected while they are on medicine. Multiple things can happen. So the relapse and the follow-up management is something that should be done with AI. So what we are talking about precisely, are we talking about any clinical aspect to be handled by AI? Absolutely not. But if we see the whole industry, it is a combination of clinical plus subclinical, preclinical plus statistical, a lot of things involved for the industry to function. So the clinical part should be handled by the clinician, but all the other aspects that I discussed right now can be or should be handled by AI. I will pause here, Dr. Parikh. I mean, if you have any counter opinion, please.
Oh, no counter opinion. But no, I am going to, before our first tea break, take some questions. I'll also answer them. I'll let Saurabh also answer some. Um, Do you feel AI will take away jobs in mental health? Absolutely not. In fact, I see AI increasing our ability to do better work. That's about it. So that's one thing,
I,
right?
I will
Um,
add one thing, doctor, because this
yes,
is a
please.
genuine concern. Let's address it. Uh, Again, let's go back with the data. Let me just do the calculation for you. So we have about, at any given point of time, India will have about 220 million uh, people who will require mental health support. What is the population of clinicians that we have in our country? Psychiatrists, clinical psychologists, counseling psychologists, add everything put together. Will it be 100,000, doctor? More or less?
What?
If the mental health professionals, clinicians,
No, I don't think we would have reached that number.
okay.
I don't think we would have reached that number as yet.
So that's what.
Maybe.
So even if it is 100,000, that is 1 lakh. And we have to cater to how many, what is the population? Two, uh, uh, two, 2.5 crores. Can we understand the sheer volume that we are talking about? Here, the concern is not whether we are, I mean, see, every time, I will also, I'll also give you one final closing answer. We are talking about lack of access. In big cities, it's a luxury. Come to the place where I am from, Bankura. 39, 40 lakhs population, that district, you can Google for that. I don't have a single clinical psychologist in that place. I mean, what are we talking about? We are talking about serious shortage of access. AI can handle that bit, and AI must handle that bit. That's the first part of the answer. Second part of the answer is technology has never replaced human being in the history of mankind. Human being with technology has replaced human being without technology. That has been the case on the
I think
history.
that's a very interesting one. Human being with technology has replaced human being without technology. Interesting one.
People
I'll
with
remember.
fire replace people without fire. People with wheels replace people without wheels. People with electricity replace people without electricity. People with computers replace people without computers. So it is about people with AI is going to replace people without AI. And that's the reality. That's the nature of reality. AI is not going to replace anything, anyone. It is people with AI is going to replace people without AI. And that's how we have grown as humanity. Let's not complain that. I mean, today if we say, okay, fine, uh, 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 there's a major activity to be done, and that can be done with computers much better than pen and paper, then there is a person who can only work on pen and paper and cannot use computers will be replaced. I mean, that's an unfortunate reality of survival of the fittest. So even for AI, it's going to be the same norm that AI is not going to replace anyone. It's people who are going to replace other set of people. So we are talking about skill building. We should be knowing how to utilize AI, how to be way more efficient as a clinician. If we will be able to consult, say, 500 patients a month, as opposed to people without AI able to consult, say, 20 or 30 patients a month. That would be the difference.
I think that's a very interesting one. And some of you also asked whether can artificial intelligence replace a mental health professional? I don't think so. First of all, I think it will help us be very clear about it. I don't see any chance of happening that. Um, you would also. How can AI replace real human presence in counseling and therapy? Not sure if people can actually connect with AI. Any thoughts on this, sort of?
No, first of all, again, I'm again repeating. In the whole thing that I said that I think AI should be there, none of them were counseling and therapy. It is about screening. That's not counseling therapy. It is about the assessment tools that are not there in Indic languages, that are not meant for India or other geographies of the world. AI should be there. Case and the note taking. That's not counseling. The habit formation, the notification and reminder, that's not counseling. Follow up and relapse. That's not counseling. So in the whole spectrum, wherein I said AI is going to come, none of that is actually counseling or therapy, because that's when we need human beings. The empathy, the real human vulnerabilities. We need human being for that, and we don't
Absolutely.
need AI for that. So I mean, that's exactly the place where we should not be using the AI.
Absolutely. My take on this is very similar. I don't think AI will replace. I think AI will help us out. And I don't think it's about the connection with the AI. All of us are interacting on text in any case, whether with individuals, bots, this, that, something or the other, we are doing that. So if you are given the right response and the right guidance and some screening to be able to reach some place, I think AI is an asset. But of course, I mean, humankind has used some of the best possible advancements for the worst possible outcomes. So if we don't utilize something well enough, that's a whole different issue, right? But this is where we take a short break. I'm the chai person, so I have to give chai to everybody in this program, while all of you have your nibu pani, juice, water, green tea, whatever you have, and it's 6:01. We meet at 6:05. I give you and my own self a 4 minutes break.
401, 405. Bye.
Oh, yeah, 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 yeah. Yeah, oh, everybody keeps correcting me nowadays. Okay, fine.
No, no, no. It's not correcting. I was like looking, is it six? Really, I saw it. I'm like,
No, no.
no, no,
Okay,
no,
let's
no.
take it.
I still have
Quick break.
time.
And we'll be
I
back.
still have time. Bye, bye, bye.
Okay, so if AI will introduce psychological therapy, then in therapeutic alliance, emotions is a big part. How will empathy? No, you're absolutely right. But try and see it in two ways. I am not anywhere saying AI will do therapy. I am talking about AI in the context of initial interface to be able to help filter and screen, to be able to eventually increase the access and reach, so on and so forth of people. Let's first understand that aspect, right? I don't know how it will be in the future. Right now, that's what I feel. Now, empathy will have two parts. When you are texting and when you are speaking, it will be very different because here there is a whole body language, non-verbal also. Now, let's say you are talking to a friend, you can have empathy on text also. So now, if you've trained your AI to be able to have psychological first aid, non-judgmental, then that response will be on a similar kind. Now, this aspect needs to be understood. But the idea is not to form a therapeutic alliance because it's more dynamic, much more dynamic in terms of what happens in psychotherapy. There is no, at this moment in time, for us to even say that AI is going to do conventional psychotherapy in a therapeutic alliance. I think it is too far fetched and I don't think it's applicable, right?
And
So,
we even
understand.
we from even AI industry don't want that to happen. I mean, see,
Yes.
the whole purpose gets defeated there because we want people to come talk to the real. Say it's like uh, quick question: do we have all the knowledges in Google? Even today we have it, right? But could Google replace our teachers? No, they could not. I mean, we Google, but then we sit in a classroom. You're still studying today, right? Do you have the option to just Google for everything and get some answer? The answer is yes. Even today you can do that. But do you do that in the real life? You don't. You go to the real classroom, you sit down, you study, or you talk to the real human being.
Absolutely. But even technology will need modification because it generalizes concept. Oh, absolutely. Uh, Everything will need modification constantly because evolution will happen in any case. Whether it was a tire or whether it was what we put in a cart for it to run, or so on and so forth, right? Would I have ever imagined when I was, let's say, 10-year-old, 12-year-old, that a car would run on electricity? That I'll have a non-petrol car? Or would even 100 years before that, 200 years before that, people would have thought that there will be cars run like this? Or so go back when people would walk miles. Would they have ever thought one day there will be something that will be on wheels? Evolution. But I let Saurabh talk about this. Saurabh, technology will need modifications. It generalizes concepts.
No, first of all, it does not generalize concept. I will disagree on one part of it. I will explain how it does not generalize concepts, and actually, I can go a bit deep into that aspect, and I will. In terms of modification, again, I modified as a human being. I mean, 1 year back, the way I used to think, see the world, I don't see it the same way. So we all modify, we all change, and technologies change, right? And then we have a very simple rule for our evolutionary biology, which is survival of the fittest. You change, if that is good, people will adopt, and when people adopt, they create new things out of that, and that evolves. If something is not good on the same evolutionary basis, it it's a time for the it perishes, right? So that's how things work. Now coming back to how technology does not generalize, and this is where we can actually use technology. So here let me tell you a few things, and we will go a bit deep into this part of the discussion. We generalize. Technology does not, because it can actually identify the nuances. And I'll tell you why do we generalize, because of the limitation. See, most of the things we talk about, CBTs, DBTs, whatever, or we talk about any medications, a new treatment line therapy, we always talk about something called randomized controlled trial. And this is how we establish the efficacy of that particular treatment line, including any therapeutic line, including but not limited to any therapeutic line. Now, what happens is in such scenarios and frameworks, the data that we gather is for the population. So, randomized control trial gives a very good data and understanding over the population. As a clinician, when you're going to treat a person or work with a person, you're going to work with that individual, you're not going to work with the population. So even if the population says that suppose there is a 30% chances of relapse of depression in a particular therapy, it does not matter. For the individual who is in front of you, might have depression with that therapy or might not have depression with that therapy. There is no 30% for that individual in front of you. So the experience and wisdom that we call, Dr. Parikh, with his experience and wisdom, what he has understood is how to extrapolate that population level data to the individual. And this is what we call as experience. And that comes, when Dr. Parikh is kind of, administering a particular medicine, and Dr. Parikh can tell that at times he actually administers medicine which is way off. I mean, would be used for something else. And he thinks that, no, for this patient, I actually will use that medicine for controlling something which is not the medicine is meant for, not for the particular population, but he does that. And that is experience. What AI also can do is, they can, because see, why do we depend on the population level data? Because if we get the individual data, the data size and the volume is so large that in a human mind, we cannot, retain all that data. I mean, you can only learn about 5, 6, 10, 500, 5,000, 500,000 cases, not more than that. You cannot know for sure what had happened with me, my mental health journey. You cannot know what is happening with all the people who need mental health support, their mental health journey individually. But AI, on the other hand, can store all those individualized data and give you individualized insights. So this is where the generalization that AI does is actually, I will say, AI can personalize more than what we as human being can personalize, right? And we can give those insights, by the way.
So I'll just take a couple of questions. Some of you've written. I'll answer my version and then we'll let Saurav answer. Is there any guarantee that there won't be any misuse and breach of mental health data? Again, I don't think this can have an honest generalized answer, because yes, some people or some individuals or some errors may end up compromising, which happens otherwise also. So I have my data with, let's say, my mobile phone provider, and otherwise, what if it gets used or misused in a certain way? The data that we keep putting in on various aspects of internet. So it will come down to the ethics. And I don't think it's generalized, which basically means we can't put all AI or otherwise. The second one, AI skills we should learn as a psychologist. I think we have the psychological skills. Let the AI try to learn a little bit of what we know. And they say that AI can replace therapy, but not the therapist. Your opinion, sir? No, I don't think so. I don't think therapy or therapist right now, either ways, is in any which way being going to be replaced. I think the role of the therapist would very much be there. But there are so many aspects that we as individuals, within the framework of our clinics and timings and the sheer limitation of as much work we can do in a week or a month, and the landscape of the deficit that is there, when you put the two together, we need to find ways where we can enhance the outreach, increase the access, bring equity, equality. At least people who require initial intervention, may not at our level, but a basic level, sometimes a lifestyle, sometimes a self-help, sometimes some guidance, sometimes psychoeducation. Some of those roles can be taken up by AI so that I have more space to be able to work where I really am needed to work. And before we go to Saurabh, there was one more related question. How to introduce AI to those population who are skeptical. People have been skeptical about most things, which change, which difference. People have been skeptical about our branch more than anything else over the last several decades. Mental health still suffers from stigma, still suffers from stereotyping, still goes through discrimination. Millions still suffer in silence. And they suffer in silence because there is stigma, right? So that is happening. Now, how can we use AI to break the stigma? Could be a question, rather than saying, is AI also a part of the stigma? For me, I would rather use AI as a part of to use it to reduce it than anything else. So those four questions I'll now let Saurav answer, and then I'll go to some more questions again. Saurav, your questions.
Yeah, yeah. So I will talk about, the that's a very prudent one, AI safety. Now, again, I will go back to my previous answers. AI is not safe. AI is not unsafe. It's the humans who use AI make it either safe or unsafe. It's as safe as the human being using it, or as unsafe as the intent of the human being using it. I was having a conversation with one of the largest hospital chains, not in India, but in US. You know what did they say? Google knows more about my patients than all my clinicians put together. That was the statement that they made. The way Google tracks all of us. Now, is it good? Is it bad? Depends on the usage of that, right? So it's like, when we were working with, like, as humanity, we were working with, like, uh, equations like E is equal to mc squared, and Einstein, and all the quantum mechanics. The purpose was not to build a, uh, nuclear fusion or fission bomb. The purpose was to just understand science. Then it can have like two aspects of that. The very fact that we are able to have this conversation is because quantum mechanics works. It works. The very fact that you can navigate through GPS because theory of relativity works. It works. So whether we are using theory of relativity or the quantum mechanics for the advantage of us, or we use the same technology as a disadvantage to us, was a decision for a Truman to make, or a Hitler to make, or people to make, not for the technology to make. So technology can be misused. Like any other technology, AI can be misused. But it is about us as human being, how much of guardrail that we create. And that's why we have to know about it right now. You know, we have to learn how to create those guardrails to start with. This is the beginning of artificial intelligence. If we all put together, come and create those guardrails to start with, we may not have similar situations to work with. Uh, then how to introduce AI to those population who are still skeptical about AI, or lack of knowledge, access of proper technology? That's a good question. You don't introduce AI to anyone. What you do is you solve a problem. So if the problem is compelling enough, if the problem needs a solution, you just go ahead and solve that problem. You do not kind of introduce a new technology by force. So basically the way we do it is, okay, fine, there is a problem, and this is the viable solution for the problem. So if the solution is viable enough, you don't have to justify that. And then second part is, we need to be transparent. So here, like, how do we introduce a new drug? Everyone is skeptical about new drug being introduced. What do? We are being transparent here. This is the study's result that has been gone. And then, yes, obviously the drug was created because there was a problem. And that's how, with the transparency and with the presence of a compelling need, is how we introduce a thing. Next one is how to utilize Stella for our academics. Stella for our academics. Yeah, if any one of you you want to work with us on, say, understanding the efficacy of Stella or how Stella works, feel free to directly drop me a mail or reach out to Dr. Parik, and we will be more than happy to roll Stella for your academic purposes, and you can do your researches on that. Next one is how to introduce AI. No, I've answered. Next one is Doctor, you're on mute.
Yes. I just got that our hashtag unmute yourself. Something I've been saying for the past decade. Unmute yourself. Unmute your compassion. Unmute your empathy. Unmute your responsibility. Unmute your feelings. Unmute your thoughts. But unmute yourself. Okay, now that I've unmuted and I took a detour, I will come back to the question. See it like this. Let's say a few hundred people want to see one individual today. That individual can see 10 people today. Out of those 100 people, maybe 15 need to be seen by this person. If there was a mechanism that an AI would screen 20 people, say that 80, this is the feedback you have, you don't need to see this person, do A, B, C, D, E, and you should probably be fine. Let's touch base again in a few days. Meanwhile, I'll keep giving you reminders. So it's narrowed it down from 100 to 20. These 20, the AI says, okay, let me screen you, and this time test screen as in a screening tool you, and why then see, okay, maybe 15 of you might need this person. Why don't you go to this person? But only since 10 of you can go to this person, a similar person with a similar skill set is also available. And why don't you do there? So on the same day, 100 people were helped. 15 who needed a different kind of intervention were also helped. And 85 others were also taken care of. That's AI helping me. I couldn't have possibly done this by myself. So that is how I visualize AI. Again, like I said, maybe 10 years down the lane, this may completely change. In any case, I've been told that I might well be living in 80s. Not really, because I got my education in 90s. So maybe living in 90s would be a bit better than living in 80s. And this was pun intended with all intention. So yeah. Saurabh, your thoughts on this?
Yeah, I mean, a lot of it, which is like, and I will address a couple of other questions that are that we are getting on a persistent basis. I mean, okay, one thing, doctor, if it's okay, I will actually demo Stella a bit
Feel
because
free. Feel
I'm,
free.
I'm I'm getting a lot of requests for that. However, it does not mean psychologists must assist AI. It's the other way around. It's the ulta. I mean, AI will assist the psychologist. So it's not this way. Next one is how can AI utilize to access mental health, and then there is screening going wrong. Okay, and a lot of and there is one question about the research that people can do on AI in mental health. So I'm clubbing all of it with your previous question, and I'm trying to answer. So
Please
let's
do.
see. AI in mental health is new. To be very clear, AI is new, right? And mental health is, I will not say, yeah, given most of the other departments of medicine, mental health is fairly new. But more than being new, mental health is probably one of the few fields which are changing much faster than any other fields of uh, you know uh, uh, of of the treatment and other uh, directions of that. The researches are typically, we are looking for 4 or 5 different type of researches that we all want to run. First one is the basic one, efficacy. Like, how do we check even if it is working, not working? How good is it working? How many? Now, when we say screening, and this is where I'm clubbing with this question of screening. See, all the screening, they do declare their efficacy, and none of them is 100%. Like us, I mean, we talk on our personal capacity. We talk to a lot of people. Do we do we understand all the intents being discussed? No, we don't. We do mistakes. Likewise, any other clinically researched tools in screening, they have their own share of mistakes. However, that does not, uh, uh, give any sort of either justification either ways to not use it, because what it does is it reduces the risk of not getting diagnosed even with its errors. So suppose assessment is 70% accurate. I'm sorry. So if a assessment is about say 70% accurate, now here we are talking about 10 people who are unserved or underserved. At least I'm talking about 7 out of them being truly served, even with a 70% accuracy. And most of these screenings are having efficacies more than 60-70%. So here we are talking about 0 versus 60. So look at that way. Do not look for 0 versus 40% wrong or 30% wrong, because see, for 30-40% wrong will always be there, but that is always better than 0 not doing anything. And next one is, what is the consequence of a screening going wrong? Very low, because it's screening at the end of the day. It's not a diagnosis. It's not giving any therapy, any medication. At best or worst, the person will go out to a clinician. The clinician will say, "Hey, don't have that." Other way around, if we do not diagnose, the person might be living with a false sense of security, and that can lead to anything. I mean, see, here we only talk about mental health that will lead to only mental health outcomes. But just for a second, understand that our body works in totality. If the mental health, and we have data, and if you want, I will share, I mean, you can contact me, I will share those researches. There are extremely prudent research from Lancet, from Harvard Medical School, THN School of Public Health, again from Harvard University. All of them suggest that up to 80% of the OPD visits can directly be attributed to mental health under or unrecognized mental health conditions. We don't talk about that. We do not talk about the fact that we are living with high cortisol level, high stress, and that is going in. I mean, I'm not talking about causality, not always, but they are putting a person of high risk of getting type 2 diabetes, putting the person of high risk of getting hypertension, cardiovascular disorder, and then they contribute to uh, other set of diseases, right? So in we look mental health on a more root cause basis, if we can have a better mental health. Now in that aspect, 70%, 80% is a fairly acceptable number, at least for me. I mean, if I have to choose between none and 70% positive, I will always choose 70% positive, right? That's the first thing, because my consequences are very low. At worst, I am screening the person with a high risk. The person will go to a clinician. The clinician will say, hey, don't have any problem. The opposite of it is, I'm unable to screen the person does not go, and then something extremely unfortunate happen. And they have those incidents do happen on our life, doctor.
So try and Um, Let me try and look at some. So I explained to you the screening bit, how I see it, right? Skeptical we will be about things, and I also feel things will take their own time, to be honest, to become how we want them to be, and that's evolution as far as I'm concerned. Can AI support diagnosis? See, try and understand it. Let me answer this from a medical point of view. AI currently is helping in diagnosis in certain medical specialities. One example that I can think of straight away is radiology, right? I'm aware about various places where AI is helping in radiological diagnosis. Please understand, it is helping, aiding, raising the bar of screening ability, not replacing the doctor. So, would maybe AI also help us better in one way or the other? Possibly. But would it replace the experts? I don't see that happening. So we must look at it from that aspect as well.
But
So
I'll
I
just
think it's a very good question you've asked, and let Saurav answer. He knows the technicality of this. Saurav, the question is there any, let's say there is a mismanagement of data that is happening. Are there any consequences? Are there any mechanisms to safeguard people? How does privacy, confidentiality, which are so important to our branch, and you have these young psychologists who genuinely are concerned about this. And we, on our day one, we started this series on ethics, right? We talked about ethics so much. So the question here is, what are those safeguards? And you were telling me the other day on that panel. So, what are those safeguards? What are the punishments, also for that matter, or the consequences? And the current laws which govern, which can give us confidence that if one is using AI, law of the land, what is the expectation? And since you also work globally, you can give us a bit of a comparison as to where various parts of the world are in terms of data privacy laws and so on and so forth, and help us understand in the context of mental health.
sure. So I'll add go to the first question about data privacy security. They're not limited to only AI. They are also important. You go to a hospital, all your details, including your lab test report, everything is there in the hospital health ecosystem, right? Now, if there is a event of hacking happen, or any unfortunate incidents happen, or you provide your blood, all your uh, lab chains have your lab reports, right? So whoever you give it to. So this is not specific to AI. I mean, I will come to the AI part. This is generic data. Now there we classify three different data separately. One is generic data, one is PII, which is personally identifiable information. What all things are there in PII, which is like your name, phone number, your address, your email IDs, and things like that. That's personally identifiable information, your location, history, and things like that. Then there's PHI, which is personal health information. So the cost for uh, uh, data breach, or the cost, not cost, like the fine for a data breach, if it is done with the active participation of the data producers. I mean, we produce the data for you, right? So we are defined as data producers as per DPDPA, which is Data Protection and Data Privacy Act 2023. It is up to 250 crores Indian rupees, one data breach. So the consequences, government of India has kept it very high, and it's one of the best global standards. So I am from the industry and I support similar things, because what it does is it removes the weeds from the useful or the serious technologists who really want to work on the technological aspect. So I really support the kind of acts that we have passed over the last couple of years, especially DPDPA. That is generic data, has nothing to do with AI. Even you do a blood test, if that blood test report comes to the person from whatever ABCXYZ lab, the lab is going to be liable for that, and the punishment can go up to 250 crores per incident, not as a whole. It's per incident. One part. Now AI safety and governance is a major question, and okay. I'm working with NASCOM to create the responsible AI framework and things like that. I'm also working with other governments. See, one thing that is coming up as a theme or the feature in most of our discussion is artificial intelligence is like aviation. You cannot have aviation safety norm for the country. No flight can function that way. All the countries should come together and have a common uniform aviation safety norm. Only then plane can fly safely on the air from one continent to another continent, like crossing 100 other countries together. AI is something of that sort. In that, most see, in USA there is one guideline which has come, which is called Biden Harris guideline on AI safety, or Bill of Rights. It's a bill still. So Bill of Rights in AI. So that is there. GDPR or Europe, there are a couple of standards which have come from India. Through NASCOM, we are trying to create a certain set of guidelines. I can tell you the major features of that. First one is the basic safety and protection that we are talking about. That's always there. After that, it is about protection against algorithmic discrimination. I know it's a mouthful. Let me just break it down, which is every individual have the right to be protected against algorithmic discrimination. Now, what does it mean? When there is any system and the system is saying something, like screening, they will have its inherent errors. Anything in the world, even we have our inherent errors. But the point is, are we doing error more for a certain type of human being and less for certain other type of human being? Is it biased by race, by language, by ethnicity, by religious belief? Then we are doing it wrong. So if the error is uniform across and we declare that error, that this is the possibility of error in our system, then we are good. That's the first part, which is protection against algorithmic discrimination. The second part of AI safety is about, in high risk AI, especially something like, mental health and all, man in middle principle, which is have a human fallback option, which is I'm not happy with the AI's response. I should have a human being whom I can go and talk to. So to be very precise, if I'm a legal artificial intelligence, I should have a lawyers in my panel. If I am an artificial intelligence for mental health, I should have mental health professionals working with us, right? So human fallback option should always be there. The third one, and it's extremely interesting one, which is explainability, and we have to talk about that. Which is, if AI is saying something, can we explain why it is saying that? If AI is suggesting something, can it explain why it is suggesting that? So that explainability is extremely important. So in case of mental health, no AI should be able to diagnose, because their AI's explainability will be severely questioned. So when I said we do not want diagnosis to happen because explainability will be in question. Second thing is, no AI should be allowed to do therapy, because for conducting therapy you need a license. Even I cannot go and conduct. I'm not a clinician myself. I cannot go and conduct a therapy. I cannot go and suggest a medication. Why should we allow AI to do that? If I need a certification, even AI needs the same level of certification with the same quality. If tomorrow AI is able to clear that, that's a question of different evening. But right now we are nowhere close to AI coming and getting into a certification wherein AI will score inside exams for secretary, or the NET or SLET exams being cleared by AI. We are nowhere close to that. However, if AI is suggesting you have a high risk of, say, depression. What is the explainability? There we provide the explainability with the assessments which are there. So if the GAD-7 score is high, we screen the person for anxiety and say that you have a high risk of anxiety, go and consult with that. So there we create the inherent part of the explainability. So what all things did I say? Human fallback option, explainability, and protection against algorithmic discrimination. These three are the major features which are coming out in terms of AI safety across the globe. In terms of data safety, PII, PHI, the norms are extremely strong for India and most of the other geographies. And per incident, if we do any data breach, the fine can go up to 250 crores per incident. Next one, how to ensure validity of answers provided by humans seeking AI. I kind of answer this question both ways. One is with human fallback option. If I do not like something, I will have an option to talk to a real clinician. So that's the first part. Second part is explainability. If I say you have a high risk of anxiety, I better administer GAD-7 before that. If I say you have a and the GAD-7 result will tell whether you are having high risk of anxiety or not, or PHQ-9 result will tell whether you are having high risk of depression or not, and not other way around. It is not with any prejudice that we want AI to function. What is GAD-7? Generalized Anxiety 7 questionnaire, extremely common by Pfizer. Dr. Iyer.
So I think a couple of things. So when you talk about screening procedure can be hampered, yes, it can be. Is the screening procedure perfect? No, it can't be. Is the screening perfect? Let's say if I am doing or you are doing, no, it is not. Is there anything which has 100% validity, efficacy? No, it doesn't. But every time the question about is that good enough? The answer is not is that good enough? It is understanding how good enough it is. What are the lapses where it is not good enough? And how can I still use it for a larger spectrum to be able to create a larger impact in an area where there is zero impact? So, if hundreds and thousands can't be helped because there aren't enough people, can we at least do something which starts the help and maybe screens, guides, educates the mass so that people would know where, whom, how, what? And a lot can be done by self as well. So, I think those aspects also need to be seen as well. Uh, Can it get mixed up with other patients' data? If you remember, I mean, I'll answer this in a very different way. I mean, Saurabh is saying no, it doesn't. So we'll let his expressions speak for themselves. But I'll say this in a different way. Would you or me ever be asked a question because my first patient was, let's say, bipolar manic and second is depressed? So is my first patient, which was poles apart to the second one pole each, would it change the way, would I carry forward that to this? We won't, right? So today's assignment, Roshni and Aruna ma'am will figure out what they are doing today. This is more of a conversation. And you're right. It's the nature of the information that we are feeding. That's why the human matters. So like what Saurabh was also saying and what I am maintaining, it's the human that matters. If I train the AI with incorrect information, again, it's my fault, right? Because I gave the incorrect information. And there are researches that need to be done. There are researches that are happening. In fact, Saurav has been a part of a lot of randomized trials, and he has done a lot of work on AI. Saurav, why don't you tell us some about some of the randomized trial experiences you've had? And I was told that you have what, a world record of accuracy or something like that. What is that world record that you have?
We have broken some world records. So first of all, let's handle two questions together. So See, that's the part with a lot of questions can be answered with the same question. What if it malfunctions? You know, is it accurate? Is it inaccurate? You know, in other domains, in pathology, in other domains, we have a lot of variance. We work with those variances. But what we try to get is it better than not doing anything? You know, and this is with that concept comes randomized control trial. Is it better than not doing anything? And then we see, is it better than doing something which is established currently? And is it better than doing a lot of things, right? So what we do is not doing anything. We call that as a control group. Then we do something. We do a sham activity of doing something wherein we just don't do anything. We call that as a placebo group. Okay, wherein they feel that they get a lot of things. By the way, you'll be surprised to know placebos work. That's real. I mean, possible. I mean, we just do not know. I mean, Dr. Pari can really scold me for saying this, but we barely understand how we work. I mean, as a human being, the whole internal machinery. I mean, as science, we could not figure that out that great. We know in bits and pieces how this part might work, how that part might work. I can give some medicine that will work, but we are extremely complicated. Like, it's very easy to understand AI, but very, very difficult to understand how we function. We have internal healing mechanism. So even if we do not do anything possible, we heal from within, from whatever situation. So that is called as placebo. So the basic first one is we do nothing. Then we pretend to do something. We actually don't do anything. If say it's a drug that we are doing RCT for, we will give a sugar a tablet instead of the actual drug. So the people will feel they are taking the drug, but nothing will happen after. I mean, nothing should happen when they take that drug. Then we also apply the drug, and then we see out of say 30 people in the three groups, if one group is performing better than the other groups or not. And from there, we try to understand if one thing is working or not. Most of the cases, I mean, if we talk about the COVID vaccine efficacy, there are vaccines wherein the efficacy was 60-70%. It went up to 90. So it started from 48% to 90%. So the vaccine which had a efficacy of 48-49%, did it have any justification to provide that vaccine? The answer is yes, because it's much better than 0%. 48% is like we immediately protect 50% of the population straight away, right? So that's how we create multiple groups wherein one group does not get anything, then one group they feel that they're getting something and they don't get anything. Then there are groups wherein they get the actual thing, and then we see what is the difference between the group that got nothing, the group that got placebo, and the group that actually got the treatment. And then we compare among these groups and see if the treatment is significantly better than doing nothing. And if it is significantly better for larger group, and that's why I told, like, all those researches happen for the population level. For larger group, if it happens for larger time frame, if that happens, we tend to understand this is probably much better than the other things to say. About the world record, guys, there are a lot of data sets, something like SNLI data set, Stanford Natural Language Inference data set, wherein it's human annotated for basically three things. One is entailment, premise, hypothesis, premise, entailment, neutral, and contradiction. I'll give you the example, which is I say that a man is speaking. Then the next statement is there's a person who is talking. Now that is an entailment, which is these two means same. Then neutral would be a girl is walking, which is these two can be neutral statement. And contradiction would be uh, uh, I can see a man in a red T-shirt who is not speaking anything, which is in its meaning it's right opposite. So with that, it asks um, different algorithms or computer programs to figure out how many such correct things can you predict, and the data set is pretty large, which is like 457,000 if I'm correct, and there are multiple similar data sets. It can happen on multiple other bases. So it's basically the way we take those exams, and with a large data set we see how many wrong things that we do. The assignments and on I'll not be able to share, so Dr. Roshni or anyone will share that with you. So what I was telling is, in that we evaluate how many of them do we do it right, and from there we kind of understand whether whatever we are doing right is of what percentage. And from the till now the global record was being held by Meta in one case, which is SNLI dataset. Google for another case. BioNLI was the data. The record was with Stanford University, so we have broken all those records, and right now our efficacy level is most of the cases more than 95,
I
97.
like how Saurabh speaks now. This one had record, that's one record. We've broken all the records, and chalo theek hai, ab aage badhte hain types. Right. So yeah, you were asking about assignment. Today you don't get an assignment. You get a short break from the assignment. Tomorrow the assignment is long. Today your assignment is going to be a fascinating demonstration that we will see of Stella that Saurabh is going to do. But that will happen at about 5 p.m. ke baad wala break. These are the last 8 minutes for this segment. Then we take a 5 minute break, and then we have a stellar demonstration. Then we'll take a question answer again. I'm going to take this. Is human touch not necessary? I believe human touch is necessary. In fact, in absence of the human aspect, I don't think any other aspect is going to function. Um, how to okay, let me see some other questions. Would medical doctors working with mental health professionals lead to better treatment for the health of issues? Absolutely. You know what, I have let me help you understand this at various levels. In my school days, if I had a minor ailment, we would have a neighborhood family physician who would know the family, would know everything about my history, and that individual would be available, accessible, cost effective, having all the genuine compassion, would also probably do a bit of guidance and psychoeducation if need be, help in lifestyle correction and diet, but also would be able to tell me, hey, I'll tell my parents that for this thing, why don't you go to a pediatrician? For this thing, go to a skin derma. For this thing, go to a gastro. So what that did was it created a layer, right? I think we've lost that a bit over the years with this over expertization. So one, that's how mental health can be supported when that layer is added. I said this earlier also. Second aspect, let's say I have gone for a diabetes treatment. Now, with diabetes, there is a higher comorbidity of depressive illness, insomnia, anxiety. So, if my diabetes treating doctor is aware about these things, then they will also be able to give the right kind of intervention, guidance, and also know when to refer to a psychologist, psychiatrist based on what's required. So, either ways, whether it is at the initiation, early intervention aspect, or for the chronic health aspect, for both aspects, if health practitioners work with us, it will be a difference. Does age matter for counseling career? In my opinion, it does not. I'm more than happy to work with people right out of their academic experience and have them go through their own journey of growth and learning. There are certain perceptions we will always have, but I believe academic is step one. Experience is a continuum in any case. But if in experience you've lost touch with academics, then experience again goes out of the window. At the core of core of success, especially in a field which is an allied field of health, we will need to have academics to be on track. We are working on screen addiction and we're using AI. Isn't it contradictory? No, it's not actually. Try and see it like this. In fact, AI can actually help you reduce your screen addiction in its own way. How about you telling the AI, you know what, keep on reminding me, and if I don't listen to you, switch off my phone, so that or remind me or ring a bell or whatever. It's the way you look at it. So my take on this, a very similar take on this, is let's look at internet trolling. When internet came into the world, and I remember the dial-up connections, right? You will hear the sound that now it's connected. It'll be so slow. Even a basic mail would take so much time to go. Some of you in this 5G generation would not even know what dial-up was at that time. But my point is, I had never thought that internet which is connecting us and helping us reach out to each other and so on and so forth may also one day have cyberbullying, have trolling, have negativity. I never thought that even a positive thing can be spun into a negative experience. But that, who did that? We did that. Humans did that. So you have the same internet, it can be used in a positive way or a negative way. Who decides on that? The individual choice decides on that. So if you have, let's say, to say something to someone, what is the ethical right way to say it? Pick up the phone, do it. In your school, in fact, when we do training of teachers and we work with teachers, what is the one thing that you can please maintain? If a student's made an error, take them to your room, talk to them. But you don't tell them in front of 1,000 people or 100 people or 50 people, you're not good, you're not good, you're not this. That does not create the learning. But the point here is, what we do with what we have is a matter of choice, is a matter of our individual ethic. And because anyone who has the ability to choose between ethics and non, which side they go will not be governed by technology. Technology is the same. It's like your car. Your car does go at 120, and if your speed limit is, let's say, 80, now your car can go at 120. Your car does not know that on this particular road, the law of the land says that it needs to be a speed limit of 80. You know, but you decide to press in that accelerator and cross the 80 mark and drive at 120 because your car can. You become the risk taker. You become prone to an accident and damage to yourself or someone else. It wasn't the car's fault. It wasn't the road's fault. It wasn't the fault of that sign that told you 80. So see it like that. I just feel that we are so overcritical at times and want to look at what others have done wrong or how something can go wrong. We forget that at the end of the day, we are the users. If the user decides to use something positively, then that will be the right case, right? Before we take a break, Mind Speaker program is an advocacy program. If you are want to join it, you can join it next year. We'll be talking about the announcement November, December. There is no assignment to date. As today's assignment is a fabulous learning we will have when we come back after the break, when Saurabh does a demonstration of Stella. And now Saurabh, tell us what you say.
Okay, now I will add one thing to what Doctor said. You know, the entire Apollo mission. Hello, am I audible?
Mhm.
So yeah,
Yes, yes.
entire Apollo mission, the computation power was about a fourth of this mobile phone's power, and with that computation power, we went to moon, and now we are making reels. Now, is it a problem with computation? No, it's problem with us, how we use the same computation to go to moon or to make reels and post it on Instagram. That's our choice. With the same computation, the
Very
computation that it takes to make a single reel is the computation that we took as a humanity to go to moon.
I'm good you are saying real, because 30 seconds does not mean that you will understand what happened over 90 minutes. Similarly, if I have to speak about something for 10 minutes and to get you to see those 10 minutes, if you end up seeing any 30 seconds here and there, You would neither understand the context, nor you would be the, nor you will get it. But that's what we become, because the shorter and shorter we want things to be, we are taking away the true, deeper, or actually the correct meaning at times as well. And both Saurav and I are not big fans of short form of content. Years back, when people started telling me that 30 सेकंड में समझा दो, कैसे समझाओ 30 सेकंड में? आई मीन कुछ सेकंड तो सोचने में ही लग जाते हैं ना, बोलना क्या 30 सेकंड में समझाओ. एंड देन यू हैव सम ऑफ द मोर यंगर पीपल सेइंग दैट 30 seconds में you should explain, but you should make sure you get their attention in 2 seconds. Not happening. Not happening. Too old for that. And we will take a short break. We come back to have a look at Stella, and then we take more questions around AI. Let's take a break, young people. 5:05 पे मिलते हैं एक प्याला चाय का हो. Saurabh with Stella Parekh.
Sure. Let me just share my screen.
Some AI demonstration for all of you young people. That's your assignment. Learn what AI can or cannot, possibly in a good or not so good way. Be the student and improvise on it. And now, Saurabh, for you.
Yeah, is my screen visible? Is my screen visible? I'm not able to understand that. Yeah, I think my screen is visible, right? Okay, so few things I was talking about. So first thing is the major thing is language. This is extremely important. I read Bangla, a bit of Hindi, so let me just you know start doing it in a bit in Hindi. So basically, the way we can solve the problem of access is just with this. If I can just write in Hindi, or get the answers in Hindi or Bangla, or how many other languages are here, you know Indic languages. This, I honestly think, is going to be extremely useful for the population at large, and on the micro level for the clinicians as well, right? So I'll do the demo in English, because it would be extremely embarrassing if I start reading Hindi. uh, I mean, my colleagues, they say, sort of, stop speaking. Hindi is not your cup of tea. Okay, so it asks, starts with kind of an open question. By the way, we have a complete app. I really encourage you to download the app in the App Store. You can just Google for United We Care. Uh, Go to your respective App Store, iOS or Android. It's available on both of the app stores. You can download that and you can start using it. I mean, even for your personal purposes, or if you want to plan anything more, do let me know. Let us know. We will engage that way. How is your day? Kind of good. Slightly anxious. Uh, okay, so most of the cases it handles things like extremely you know uh, common questions, and I was talking about preclinical, subclinical activities, right? So this is a preclinical activity, right? I'm slightly anxious. I have to demo it. I don't know whether uh, 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 hmm, yeah, I mean, and if you see the answer, I completely understand. Sort of, it's normal to be anxious before a big presentation. Can you tell me more about what's making you anxious about this demo? Is the fear of rejection or something else? So it's So can you see that it is giving me the answers extremely contextual? It's able to understand. However, with this, what you can see is it's also trying to nudge me onto things like, do I want to go through some resources on anxiety? Because this is important. If it is, I'm anxious because of a reason, or it has been there with me, I do not know. Now, here, if I say yes, then it will say, do I want to assess my anxiety levels? And from here, the someone was asking what is GAD-7. That's a generalized anxiety disorder 7 questionnaire, and it's a Pfizer questionnaire, and all these questions are clinically tried and tested with randomized controlled trial. It will also say that it is intended to be used by healthcare professional, and I understand. Do I wish to proceed? Yes. And it's for now, it's going for the last 2 weeks, at least last 2 weeks. Do I have this problem, feeling anxious or on the edge? Probably. And don't judge me, this is not my answers, but I'm just answering it. Let me have one or two questions in other languages. I don't read Hindi, but I'll just show you one in Hindi. I'll just go back to English. So my point is, people can do the whole thing in Hindi or any other languages of their choice. I have 3 more questions to go. I'll just finish it quickly. Now, this is the GAD-7 score, which is 16 out of 21, which is indicative of, now we are talking about a major, the screening is done right here and right now. And now it is also suggesting, please talk to a psychiatrist, because my score here at 16 out of 21, it's a severe anxiety. This is where the screening happens, right? Self-evaluation. Now we understand this is a self-evaluation. We do not say you have anxiety. It's indicative of severe anxiety. Here are my recommend you to consult a healthcare professional. So when we were talking about we need to go and do the triaging, this is where the triaging is happening right here, right now, right? So I can click on this, I can check for the available slots for this particular clinician, and I can it's available on say 5th July 7 p.m. I can book. I'm not booking it. It's that I'll actually book the slot, and all our clinicians are from Fortis. So yeah, I mean, this is the best version of the AI. If you want more detailed version of the AI, I, I just pause for Dr. Parik to kind of uh, uh, be back. And yeah, it also recommends psychologists, but the score was way too high. That's where it thought it will recommend a psychiatrist instead of a psychologist, but in a range which is in the mid range, it would have recommended psychologist as well, right? So no, see, the thing is, the questionnaire we have not decided. The questionnaire is as per the GAD-7. That questionnaire is clinically tried and tested. We will not change comma or full stop in the questionnaire, because this is where we provide the explainability. What I was discussing just before the break is about how can AI provide explainability, is because we go by the clinically tried tested questionnaire, and those questionnaires have their independent clinical validity. And if the questionnaire in its current form is suggestive of something, then it is certainly suggestive of the something, not
So
otherwise.
try and understand a couple of things. Uh, Please be very clear about it. One, screening tools can be screening tools for the clinical population only if they have validity. Non-clinical, and non-clinical would be, let's say you're talking about something related to relationship where a psychiatric diagnosis does not have a role to play. And understand these differences, right? Be very clear about this. That when you look at a clinical tool, it will be something which is standardized and has validity. That is being used only as a screener and not as a diagnosis, right? So if I go and I say I'm having a bad day, and my psychological first aid says some people have bad day, it's okay. What is it? And I say maybe I had an argument. Okay, would you want to use relaxation? Show me something. Would you want to some mandala, some journaling? I'll tell you how to go about it. Is it happening more often? Have you had this? Are you feeling this? Or would you want to be, can I screen you for this? So on and so forth. So for every problem, a person does not need to go to a professional, right? That's one part of it. Now, when you talk about how does, so this was one AI, which is the United We Care and Adayu's app. Now, there is a layer available before you see a mental health professional, unless you want to directly go. That's obviously a different issue. Second, you also have an option that because there is not necessarily a need to go to a mental health professional, you may well do some self-help, self-correction. So both things need to be understood when we talk about what AI actually is doing. Now, would AI come first? Typically, yes. Can AI be used after a consult, let's say by me or a psychologist? Yes, that's also possible. Then I may say, okay, for this, why don't you go through these videos and there are some prompts, or you want some affirmation prompts. So some cognitive related work can happen, some behavioral prompts can happen, some relaxation guided imagery can happen, so on and so forth. So you'll need to look at those various aspects. Uh, what else was there?
I will address one question by Dr. Kalpana Gautam. So that is about what happens to the efficacy of the assessment when we translate. Extremely important, and this is where we started the whole conversation with that AI should be able to translate. Now, because it's screening, let's understand a couple of things. I do it in Hindi. I do it in English. I have certain level of accuracy for the screening, which is being given by the original study design. Okay. Now, when I do it in Hindi, what happens is I will see whether my efficacy is similar to that or not. Then there is one more thing that I and Dr. Parikh, and we have written about 6 papers on that. If anyone is interested, I'll share those papers. There is a WHO working group guideline on mental health, translation ability of mental health assessments or screeners or batteries. You know how it works is we take it from the source language, say English, and then there is a destination language, say Tamil. Now the process is there is a bilingual panel who will foresee the overall translation methodology. Then there is a forward translation. A forward translator, he or she will do is take the questionnaire, translate that from English to Tamil. Then there is a back translator involved in the whole process and tell you where AI will come, or we are doing the research and AI has already come into that. There is a reverse translator or a back translator who is going to translate the translated version of Tamil back to English, which is, say, original question is something like, we are feeling anxious or nervous or on the edge, the first question. Then we translate it to Tamil, it becomes something. then we translate back to English from the translated version to Tamil, is when we see how different are they. These two sentences are being given to the bilingual committee. They will discuss, debate. They will either tell the translator to do the translation, forward translation better, or the back translator to do the reverse translation better, and come back to them. With AI, what we can do is we can make the job of the bilingual panel irrelevant, which is, if with AI we can measure the distance between two, how different are these sentences, the original sentence versus the forward translated, back translated sentence, that's also in English, right? So if we can mathematically measure the distance, and we have a commonly acceptable criteria for the distance, that the distance should not be more than, say, 5%, 10%. I mean, 5-10% variance will always be there. But if the distance is no more than 5% to 10%, I know the maximum loss on translation one side is no more than 2.5%. That is acceptable. So whatever is the acceptable criteria, even with a human one, because we have done the research, we can see there is no translation in the world which is a perfect translation. We can, keep this as a game, or you can just answer it here in your language. So let's choose one language which we, most of us, can understand. I don't, but Dr. Parik does. Take the first question of GAT 7, and I will share the exact question. So the first question is, feeling anxious, nervous, or on the edge. I think that's the first question. Can you help me translate? Yeah, feeling nervous, anxious, or on the edge. That's the first question of GAD 7. Can you help us translate that to Hindi? Any messages? Feeling nervous, anxious, or on the edge. Can you, any of you help us translate that to Hindi? And trust me, you are going to do that on a day-to-day basis. I mean, as a clinician, you are going to ask similar questions any which ways. I mean, you may not ask the same question, but even if you're घबराहट, हाँ मतलब, but what would be the whole sentence? Because I will then ask someone else to translate that Hindi to English back. क्या आपको बेचैनी हो रही है? Now, Dr. Parik, if someone is telling कि आपको बेचैनी हो रही है, how do you translate that to English?
Are you feeling restless?
Are you feeling restless? Yeah. Now you see, the original sentence was feeling anxious, nervous, or on the edge. No amount of translation, even with a human set, we do understand it's fairly accurate. But even that, there, we cannot guarantee that when we translate it back, the meaning is the same. क्या आपको घबराहट या बेचैनी हो रही है? Now this is very close. क्या आपको घबराहट और बेचैनी हो रही है? Dr. Parik, if I have to translate that. क्या आपको
Are you feeling anxious and restless?
Anxious or restless? Okay. So we are getting closer and closer, but that's nothing like we can always reach to the original point. It's impossible. If I do not fix the game in the current ecosystem, we cannot. Now you understand how important it is to have AI. How important it is to have AI. We cannot even translate or agree on one translation with all of the people put together. We cannot. Now, going back to Dr. Kalpana's question, please understand AI is as accurate as human being can be. Will it have bias? Yes, it will. But those biases are also there with human being, and trust me, the biases in human being is much higher. Just read through the comment for the same set of questions. And this is why I actually did this experimentation live, to make you realize how important is AI in the domain that we function. And just imagine now, someone as a clinician, if we are spending so much of time just to explain the question to the patient, are we really performing as a clinician, or we are just working like a translator? That's not our day job. Or are
So,
they?
so moving forward, I'll answer this question. Then, when you say Stella trained as CBT, so I will explain this to you. Um, the school of thought on which Stella is trained comes from the cognitive behavioral school of thought, which does not make Stella a cognitive behavioral therapist. Being trained in CBT, right? Which means using cognitive techniques for psychological first aid, which is first interaction. That's about it. So when you are saying that it's mentioned that Stella is trained in CBT, the school of thought. So Stella psychological first aid are on the lines of cognitive and behavioral. They are not using, let's say, dynamic, humanistic, and some of the other theories. That's about it. But let's be crystal clear about it. And I have an absolutely unambiguous view on this. Where we stand today, I do not see AI doing therapy today. And I do not see AI replacing a therapist tomorrow. I see AI today having started an initial infantile stage of its journey where it has started aiding in certain aspect of in this entire landscape of deficit of experts. It can do a bit and thereby helping in reaching or creating a better outreach. Right? That's one part. The other part that some of you asked, that would you want to be a part of this? Then, like I said, this is a journey. What is happening today is a start journey. We are learning, sort of learning, and we are improvising. Why? Because the goal is very clear. Mental health as a universal human right, mental health as access, mental health in an affordable manner, and an outreach where almost anyone and everyone, equity, equality, affordability, access, all of that. But one individual, one group, one innovation, one company cannot possibly make an impact. It can make, I mean, what would I do? My entire lifetimes for 30 years of work I have done is what? It's like a droplet of an ocean. We need so many more people to keep pooling in to make an impact. That applies to our knowledge also. What is our knowledge? Experience, education, quality. What's my knowledge? This much. What I don't know, mammoth, huge, gigantic. Who am I to say that's incorrect, this is correct? What I can say is based on what evidence there is today, this may or may not be fitting in. But who am I to, without testing it, say, no, no, doesn't work? Because that also is a stereotype based slash narcissism in its own way. So when it's mentioned the Stella is CBT, it's not being a therapist. It's using the school of thought and nothing more than that. And no, today we are not giving an assignment. This was very much planned. One of the reason being today is our only external speaker, technically a non-mental health speaker, but who knows a lot of mental health. But so in our entire 24 experts, the only expert who was an external expert was Saurav, and that's why we thought today instead of assignment, we'll let you explore the world of AI, but we'll match up your. I know how many hours of assignments you need to do. They'll give you a longer one tomorrow.
So sorry, guys. Okay, I will address one more follow-up question by same Dr. Kalpana, and I will add to a couple of other things. Name of the application is United We Care. You can go to your app store, download that app. It's comprehensive. Just use it. That's first thing. Would you call this a statistically efficacious? Oh my God, mouthful. How do I establish statistical uh, mm, validity, or how can or how do I call something as statistically significant? Because the way we use it is statistical significance. First of all, we choose a value of uh, you know a cutoff. We call that alpha value, right? So which is, I will choose that the error in my judgment cannot cross 5%. We call that alpha. Is there any reason for choosing alpha as 5%? The answer is no. Then we get a p value. If that p value is within that range of alpha, we call it statistically significant, which is, we always say p hacking, p value less than 0.5, sorry, 0.05. Can anyone Google it and tell me why p value is 0.5, 0.05? The answer is no, nothing. It's just a commonly acceptable thing. Can p value be 0.01? Yes, in cases. Can p value be much lesser? Yes, in different cases. But the thing is there any commonly acceptable or is there any reason we keep the p value as 0.05? The answer is no, we don't have any reason to do that, but we just do it. So the same way, if we keep the same p value of point, if we keep the same p value of 0.5, because it's a bidirectional translation, we keep the overall error as about 10%, 5% each side, and overall 10%. And doctor, trust me, you can do that experimentation yourself. Do it with any questionnaire. Do the forward translation. Get the back translation done. If it is more than 90% correct, you will be extremely happy with the translation. We go by the same criteria. Is there any benchmark of the criteria? None of the statistical parameters across the globe does not have any benchmark. So we take as a commonly acceptable thing as confidence interval as 95%. That means my possible inaccuracies in the claim as 5%. We keep that within that. Data science works. Same way human being works. I mean, you can just test it all by yourself. Oh yeah, diagnostic and statistical manual 5th generation text revision. That's the world that we are into, any which way. So it is statistical. Mental health is statistical. Doctor, sorry.
I must say there are so many of you asking for assignments. You make me so proud. 100 of you have asked me 100 times. No assignment today. Such nice young students who want assignments every day. I appreciate. Your assignment, unmute yourself. Do something positive. If you are on social, spread a positive message. Say something nice to someone. Do some advocacy. Create some awareness. Do something positive. Unmute yourself. That's also an assignment. But that's a sidetrack assignment. Roshni won't give you marks for it. I would, but wouldn't my affectionate marks be any day more important than the strict marking of Roshni Sondia be? Don't tell her that I was telling you this, right? Affection wins over the strictness of statistical marks. Okay, and we have very little time left, so we'll take some
all the questionnaires. See, there are two again. Doctor answered that question. There are two type of questionnaires. One is clinical. All of the clinical questionnaires have clinical validity. Then there are subclinical, preclinical part like relationship, leadership, host of it. They do not have any clinical validity, nor do we even claim that. Last but not the least, please understand these are not diagnostics. We do not do diagnosis. We do screening. Please look at from that lens. Do we have any better option to screen in scale than AI? That's my point here.
No. So when you talk about referring on high score, that will follow the standardized guideline. So which basically means, let's look at an example of depression, right? So if someone, let's say, has mild to moderate depression, guideline is therapy. If somebody has moderate to severe, guideline is psychiatry needs to be done. I mean, this is a guideline. Why? Because in moderate to severe, because of the severity, which may also include some more factors which can cause significant concern. So that's why it's not about a hierarchy, it's about guideline of what level of intervention. Also, always remember something I had maintained: combined treatment efficacy is proven without doubt. If when you say moderate to severe, refer to a psychiatrist first, does not mean that this individual does not require psychological intervention. And that's why when you are looking at combined treatment, which one starts first or which one starts second is not the point. Whatever is needed, was it done or not? So, if somebody needed psychological work, why is it not happening? And why only medications? Or if somebody needed medications, why only sessions happening and not medications? So, this is more a guideline: mild to moderate, psychologist, moderate to severe, psychiatrist. It's more about the guideline, nothing more than that.
I will do one thing, doctor. Just for the, I love transparency. So let me just actually show the guideline of GAD-7, the actual one, and then I will show what the app does so that we can clear all the doubts once for all, if that is okay with you. So I'm just sharing my screen. First, I'm going to share. Now, this is the GAD-7 guideline. So the questionnaire that is being, so this is how this one happens. This coding guideline is not something that we provide. So 15 or above, it's a severe anxiety. Now, as a clinical protocol, Dr. Parikh and team, they decide if someone has severe anxiety, the first line of treatment the person should go through would be psychiatrist, not psychologist. But here, if you see, is my screen visible?
No.
Sorry. There's one thing which has come. I'm actually sharing it.
Meanwhile, Saurabh, a very interesting question, and since we are transparent and honest, one user has said that Stella is persistently asking for professional help thrice in 2 minutes. Why is Stella doing that? You are supposed to reduce our workload, not increase.
I understand.
On a lighter note, maybe it may not sound the best, but it looks like it wants sales. But before you answer, I will answer it. Right now, Stella is not directly working with individuals. Right now, what we are doing, we are working only with organizations. So there is zero cost of using the expert to the individual once the organization is working with it. The idea is not to look at the sales component, and I'm taking it in the spirit that you've written, and I appreciate it. I like young people asking the right questions, but try and understand it. Right now, it is not direct to anyone. So if somebody today directly goes and wants to reach a psychologist through Stella, we are not doing that. We'll do that when we feel that it's there. Right now, for you, it was more to see how AI can interact. Yes, sometimes you would have found errors, sometimes you would have found benefits. That's the idea, which is why the slow process of evolution, which means taking one step at a time. But where we are now with Stella, we're very clear about it. So even if it would have been referred or not, the consumer or the user or the individual is actually not paying for it. So just so you know, and
Now-
cost in any case.
Okay, now I'm answering from the other side of it, and this I really wanted to do during this session. Extremely important part. I know, Thursday 3-hour session is probably the most boring part of the day, of the whole week. It's not even Friday that sorry.
What are you saying?
Yeah, I mean, people are listening to us, doctor. I mean, actually, I am.
Yeah.
So people are actually listening to me. I'm like, I mean, Only thing I can convey to all of them is my condolences and my pity to all of you listening to me.
He's giving you condolences to be tolerating me for 3 hours.
No,
Come
doctor.
on,
It's
yeah.
me. Guys, and this is something that is going to stay with you if you work a bit on the statistical part of the mental health, because it is statistical at the end of the day if you wish to. In statistics, we talk about two different type of errors. One is false positive, one is false negative, and both of them are problematic. But then one problem we perceive as more problematic than the other problem. I'm just giving an example. Say, suppose someone has depression. Now I classify that person not to have depression. Or someone needs a clinician, and I say you do not need a clinician. That is one type of error. Second type of error is you do not need a clinician, and I say you need a clinician. You do not have depression, and I say you have depression. Both of them are errors. But one error is more damaging than the other type of error. And that's why you see statistically it is slightly biased towards that. I'll tell you it is biased, and I'm telling you it's biased. A false negative is always more problematic in the medical domain. Please follow that principle always if you are working on the you know uh, mm, medical sector, statistical research or anything of that sort. If someone has cancer and we classify you do not have cancer, it's a bigger problem. If someone has depression and we classify you do not have depression, is a bigger problem. If someone has needs a clinician and we classify you do not need a clinician, is a bigger problem. Then you do not need a clinician and classify you need a clinician. You do not have depression and classify you have depression. You do not have cancer and I classify you have cancer. You know, that's how it is always biased, because the cost of not detecting it on time, because probably you are testing it, but probably for someone else this might be a question of life and death, and I just do not know. From a simple sentence I am feeling low, whether the person is on the verge or on the edge of something drastic or not, we just do not know. Because we do not know, because we talk about the safety of artificial intelligence, we always bias it towards reducing false negative as much as we can. If we have any doubt, any indication that the person needs clinician, I am going to recommend the person to clinician no matter what. So that's the premise and hypothesis that we work with, and we strongly stand by that. Now in future, without reducing or without compromising on the possibilities of false negative, if we can do it better, that's when I will shift it other way around. Even if it sounds like a salesman, first of all, we do not charge anything to anyone, but my purpose is not to make any salesperson. My purpose is to ensure we help people. And in the pursuit of help, if we have a doubt that the person really need a human clinician help, if even if there is an iota of doubt, we are going to suggest the person of human help. If I could answer the question.
And be very clear about it. It's not about a recommendation to psychologist or psychiatrist, since the team works together. So if person A goes to a psychiatrist, the person A requiring therapy will be referred to a psychologist, goes to psychologist needs meds will be referred. One team, one cohesive program. The other aspect is, if you'll just look, there are a handful of psychiatrists and a lot more psychologists. There are also some wellness people, which includes nutrition and physiotherapy. The whole idea is that we need to look at lifestyle, biological, psychosocial, all aspects of connection. Uh, if you've coincidentally posted something related to mental health today already, I am very grateful. And I wish this coincidentality happens more intentionality ke saath, more regularly. I'll be even happier. Okay, let me just take these last few. Can you get placement opportunities? Uh, you will get placement. We have a huge deficit of experts, and there are hundreds of places to work. Trust me. And you've met us, you are going through some learning with us. That does not make us better than anyone else. I think every individual try to do what best they do. I don't think there is a better or a worse, to be honest. And I fundamentally believe in that. Thank you. Lots of you are being grateful about what Saurav has taught us. I appreciate. I also appreciate a lot because I keep learning from him. It's just there is so much data coming from a data person that my limited ability to store data, there is more data coming in, I have lesser ability to control, and then and all that happens to me. Today's session was very interesting. Thank you, thank you, thank you. You want Saurav Sal's mail ID? I would love to give it, and I would love to have his mailbox have a few million mails. Why should I be the only person who gets messages that I don't want? Right? We should give them to Saurav as well. I will give the ID to you. 1 second. For all of you, especially for you, that is Saurav Banerjee. No, SB. It is SB. Look at the humility. SB, right? SB at unitedwecare.com. SB Saurav Banerjee. SB at unitedwecare.com. Please send him one question per all of you. Let's give him about 7,000 to 8,000 questions by tomorrow morning, and let's bring it on. Yeah.
Yes.
No, we don't have assignments today. Your assignment was to explore the world of AI, but you'll get enough assignment tomorrow. Nice students asking for assignments and assignments and assignments. Okay, let me just quickly go through if there's anything else left. Got something valuable to learn today. Thank you. Not boring. I agree, I'm not boring. We should tell that to Saurav. Boring.
I am boring. I told I am boring. Such a boring person. I'm like, how do you tolerate me? No.
Yes. So I think if someone's, let's say, and please understand this. If I go to a clinician, I mean, let's remove the AI context here. If I go to a clinician, the clinician tells me you have anxiety. If it gives me anxiety like you asked, it's the job of the clinician to reduce that anxiety also, to put it in a context, to tell them what the prognosis is, tell them how it will go away. You deal with that aspect also. But I don't want an ostrich happening here that I won't tell you because it may worry you, and that means I will not do the intervention, but that will only create more problems, right? And the reason why a lot of mental health related concerns continue to be there, and 3 in 4 people, young people, don't forget this, 3 in 4 people still don't seek any kind of intervention, primarily because of the stereotypical stigma, because of the narrative, because of the perceived discrimination and the actual discrimination, because of the lack of access as well. There are so many aspects here. And we have to, with all humility, understand that for generations and decades, there is so much around mental health which is still having an impact. Just because my algorithm on my social media feed gives me more reels and videos on mental health does not mean more people are talking about it, and does not mean that more people are accepting it. Do not allow yourself to believe that. The people not seeking or not accepting is far more than those who are. And that's where probably our impact needs to be there. Okay. Today's assignment done. Marks are as many as you want. I believe in self marks, and how about giving yourself at least 101 on 100? The way the world is, I remember when I was learning in school, my English teacher, out of 10, he would get a 3, 3.5. 3.5 is like brilliant, right? It used to be like, wow, ma'am's given you 3.5. And from there, the world today is getting a 98, 99 in English. So, but I believe best way to give marks is self marks. If I can't judge how well I have done, who is somebody else to judge me? And if somebody else is still judging me and I still don't get it, then the judgment won't matter, right? So if my ability to introspect in front of the mirror continues to be with insight, I won't need somebody else to give it to me.
Okay, by the way, I'm Calcutta dropout. When I say it, I just carry it with me. So yeah,
Okay, so I think let's wind this up. It was a pleasure, Saurav, as usual, speaking to you. Where 3 hours went, I didn't even know. And I just had 2 cups of tea, 1 cup of iced tea, and had half a paratha, some water, and some of those jam. What are they called? Jim jams. I just know it has a jam in between. I just love that biscuit.
doctor, I'm missing, all those hoggings at your place. Like every time I go to Gurgaon, I'm like, I have to visit doctor. I mean, we'll
It's life. Life is more so much about finding the good moments. You have two options in life: to screen for misery and negativity and spread it because it is contagious, or to screen and try and deliberately choose some joys because joy is also contagious. The choice is yours. Do you spread happiness and positivity or negativity? On that note, and on this journey of artificial intelligence interfacing with mental health in years to come, a lot of you will be there. I'll be long gone, done with by that time, but you will be there taking the field of psychology forward with innovations that the digital data and the AI world would have. And on that note, we thank Saurabh Banerjee, sir, for being here and giving us so much insight on AI. And all of you, we meet again tomorrow, same time. I don't remember tomorrow's topic, so I'm sure you would. And I will not know tomorrow also it was, one second, what is it? Jim Jam. Be very clear about it. That is how much I remember. Tomorrow also when it is served, when I will get it, and it's right here, right behind me in that box, okay? I will still not know. So yeah. Now, on that note, unmute yourself. Let's say goodbye to Saurabh and we meet again tomorrow. Saurabh, you want to say goodbye to us?
Dr. Parikh, it's always a privilege talking to you. I mean, like, honestly, doctor, thank you so much of having me here talking to so many people. Thank you.
Thank you. Thank you, everyone. See you tomorrow, young people. Unmute yourself today. Bye bye.
Bye.